دكتور نجيب.
الختام. Hello everybody. Anybody is still awake?
Yes, we are waiting for you.
Okay, I will need a clicker. Okay. I'm going to speak to you about something that's very, very, very important. I think so. First, of course, I thank my mentor and my elder sister, Professor Ines, for giving me this opportunity to see all these fighters and the strong-willed people who are still surviving till 9 p.m. to listen to MOHAMED-NAGUIB WIFI, who's not a diabetologist, and speaking to them about the liver. Okay, why the liver? Because liver is going to be everybody's work, I think. This is the new pandemic. This is the commonest disease. This is maybe even more common than diabetes, the liver disease. So I am going to speak about two important and lovely issues for everybody, obesity and liver. And the clicker is not working, I guess. Okay, it's working now. Okay, of course, you have known this very well, that there are so many people who are obese, and you have heard lots of numbers from all the professors before me, so it is of no use to tell you that. It's even now invading children and adolescents, and of course you are oriented that obesity is affecting almost every single system in the body of a human being, so it's also no use to tell you about the complications and the medical problems of obesity and their relationship with metabolic syndrome, and to the extent that they included liver disease or non-alcoholic fatty liver disease as part of this metabolic syndrome. So you all know about type 2 diabetes, hypertension, hyperlipidemia, chronic kidney disease, cardiovascular, and obstructive apneas, and also all the musculoskeletal and even malignancies. So these are the complications of obesity. So what is non-alcoholic fatty liver disease? There was a time where every person who goes to a doctor, he performs maybe an abdominal ultrasound, and he tells him, because he's seeing that the liver is a little bit white, oh, don't panic, it is just some fat on your liver. Or maybe this very nice patient with diabetes, and he's following up with his diabetologist, and he makes the routine labs, and he finds that the transaminases are a little bit high, and his diabetologist tells him, oh, don't panic, it is just some fat on your liver. So do you really still believe that the issue is still, oh, you have some fat on your liver? No, this is not. The non-alcoholic fatty liver disease, which is primarily, there is excess fat, of course, in your liver, more than 5% of your hepatocytes, carries a very, very wide spectrum. The very minimal part of this spectrum is this fact of, yes, you have some fat on your liver. But the rest of the spectrum is much, much more dangerous. It includes non-alcoholic steatohepatitis. And when I say hepatitis, it means inflammation of the liver. It means that it is similar to hepatitis C, hepatitis B, any hepatitis. It is a hepatitis. And since it is a hepatitis, it can also go through the whole dilemma of a hepatitis, from early fibrosis to advanced fibrosis to cirrhosis, and maybe to hepatocellular carcinoma. And not only that, non-alcoholic fatty liver disease maybe go to hepatocellular carcinoma without passing the whole way. At any stage of non-alcoholic steatohepatitis, you can simply discover this, and unfortunately, just a couple of years ago, we have lost a very dear professor to ourselves, a professor of hepatology, because he developed hepatocellular carcinoma out of non-alcoholic steatohepatitis, and he did not have a cirrhosis. So, okay, so the definite diagnosis, of course, needs a biopsy, but there are other tools to diagnosis, and this is the histological features of the spectrum of steatohepatitis passing to the cirrhosis, from normal to steatosis to steatohepatitis with ballooning and degeneration and with fibrosis and advancement of fibrosis, and lastly the development of hepatocarcinoma. This is the global prevalence of non-alcoholic fatty liver disease, and what concerns us that it is almost 25% of the whole population. That's why I told you this is more common than diabetes. So non-alcoholic fatty liver disease is 25% of population. In some areas, it's even higher. Here in the Middle East, it's almost more than 30%. More than 30% of population in the Middle East, they have non-alcoholic fatty liver disease, and 10 to 15% of them, they have already advanced fibrosis and cirrhosis if we perform liver biopsy to them, and they are just walking among us and they don't complain from anything. So this is the spectrum with the number of millions. Prevalence of NAFLD and NASH in high-risk groups. This is obesity. This is the spectrum of NAFLD up to 95% of obese. This is the spectrum of NASH up to 50% of them. Type 2 diabetes, it's not very far away. Almost 80% have NAFLD and almost 20 to 80% having NASH. So it's also in obesity, also in type 2 diabetes. They both have NAFLD and they have NASH in that. NAFLD, BMI, and type 2 diabetes, and please pay me some attention when I'm speaking about body mass index, and I thank Dario very much because he the first one in this session who pointed us that BMI should not be our only sole measurement of presence of obesity and things like that. Of course, any increase in kilogram body weight carries a higher risk of development of type 2 diabetes and NAFLD, almost 38% increase in BMI, or 10% in every 1 centimeter increase in the waist circumference. And in type 2 diabetes, the risk of NAFLD is independent of BMI. It means that diabetic patients, they can develop NAFLD even if they are not obese. And this is the prevalence in patients with severe obesity undergoing bariatric surgery. We can see that it is very, very high, up to 93% of patients, they are having non-alcoholic fatty liver disease while they are going to bariatric surgery. This is the prevalence of fibrosis, and we can see also that the prevalence of NASH and advanced fibrosis are increasing in obese patients and in people with type 2 diabetes, and the global incidence is up to 37% in type 2 diabetes, and those who go for liver biopsy, we find that 70% of them, they have advanced fibrosis, which is cirrhosis, not only NASH, not only hepatitis. 17% they have already cirrhosis. So this is the evidence supporting the progressiveness of this, that the amount of persons who are performing liver transplantation nowadays, they are acquiring less HCV patients and they are having more non-alcoholic steatocirrhosis patients to perform the liver transplantation. See, after we eliminated hepatitis C and other causes of transplantation, see how the spectrum of NASH people who are performing liver transplantation, it is rising. It is similar to the dollar now, same thing. Okay, so the clicker sometimes. Okay, what is the pathophysiology? Of course, this is the part that everybody hates, is to describe how things happen. The pathophysiology is, we have this two-faced coin between obesity and liver disease, okay, and metabolic syndrome. It is what's called multiple parallel hit theory. It was called only multiple hit theory. Now it's called multiple parallel hit theory. Why? Because multiple hit theory gave us the idea that you pump in one hit, then you go through your way, then you hit in another pump, which is the second hit. Nowadays, it is not believed that they are first hit, second hit, then a third hit. Rather, that they are parallel hits with variable grades, and they are just interacting together until you, as you can see, I know that there are 10 minutes remaining. Okay, hits interplay together with different pathogenic combinations. Okay, the expansion of adipose tissue is the start of the problem. This expansion, of course, diminishes the ability of storing excess energy. This leads to adipocyte dysfunction and the development of insulin resistance. Consequently, there is free fatty acids, leptin, adiponectin. All those things have been mentioned before in the previous lectures. This results in intrahepatic fat accumulation, and this also stimulates the immune cells. The interrelay between this and that leads to chronic intrahepatic inflammatory process, lipotoxicity and the glucotoxicity. They work together in the development of this, along with mitochondrial defect, endoplasmic reticulum stress, and oxidative stress, and voila, what is the end result? Of course, you now know that is aggravation of fibrosis and stimulation of hepatic stellate cells. This is the هو الكليكر ده بيعلق. Can I have another one? الكليكر ده بيعلق. Okay, there is the interlay between genes, environment, and the multiple hits. And of course, the genetic modifiers, they look like the, you know when you forget your password and you click, I forgot my password, and they send you just a few numbers and a few letters to regain your password again. This is the type of genes that are entitled in the genetic modifiers of NAFLD, like PNPLA3, TM6SF2, MBOAT, and the HSD17B13. Very easy to remember, of course. Okay. What is obesity and NAFLD? It is an independently linked risk factor. It is a higher risk of NAFLD with a hazard ratio of 3.6. And here is the point that I told you, what is called lean NAFLD. A relevant issue that there are persons who are metabolically obese but with normal weight. MONW. This is a new name we have to recall. Metabolically obese, normal weight. These have obesity without having an elevated BMI, and they behave like metabolically having a metabolic syndrome, and as if they have obesity, and they are metabolically unhealthy persons, although they have a normal weight. The second phase of this, of course, the effect of liver fat on the metabolic syndrome. It increases all the aspects of metabolic syndrome, you know it, and it is proved with MR spectroscopy. The presence of fat in the liver cells is accompanied with all the components of metabolic syndrome, like hypertension, dyslipidemia, blah, 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 blah. Okay, so aminotransferases also predict the 20-year risk of metabolic syndrome in those patients. The elevation of ALT equals bad diabetes, bad metabolic syndrome, and so on. Liver fats also are associated with the cardiovascular risk. Thank you, Professor Gamila, because she mentioned that in her lecture, and now there is this marriage between the hepatologist and the cardiologist as regard the liver, and it's called the liver-heart connection. We have always wished for that. So, the random effect of and meta-analysis, the risk of the cardiovascular disease, of course, Professor Gamila, she mentioned that very much. We can see that all the data, they are on the right side, which means they are increased risk of cardiovascular events. So they can even say that those patients with liver disease, out of obesity, they have a cardiovascular disease, and they will eventually die from the cardiovascular events, not from the liver-related diseases, not from the liver cirrhosis and the hepatocellular carcinoma. They are more prone to die from the cardiovascular risk and the myocardial events before they die from their liver disease. So be aware that presence of liver disease means that already the heart and the cardiovascular system is affected, and these are the clinical predictors of NASH in persons of NAFLD, like having advanced age, sex, race, presence of other aspects of metabolic syndrome like hypertension, dyslipidemia, diabetes, and of course the AST-ALT ratio, the reversal of AST-ALT. Of course, we know that ALT should be higher. This reversal of this ratio means that this patient most probably have developed cirrhosis. It is something simple, and you can see it in your clinic. Ask for AST-ALT. If you find that the AST is higher than ALT, this patient is cirrhotic. Okay, it's very dangerous and very freakish. Yes? This is the natural history. Of course, increased mortality because of hepatic and extra hepatic causes, as I mentioned. Okay, the risk of liver-related mortality, as we said, all-cause mortality are higher and rising, and most of them is the cardiovascular events, as we said. Hepatocellular carcinoma, they are very common to develop in patients with NAFLD, even without passing to cirrhosis, from 14 to 20% and higher, of course, in obese, as we have mentioned before, also with type 2 diabetes. And these are the survival curves of hepatocellular carcinoma with liver disease. Of course, they are worse when they are obese. So we come to the last 4 minutes of our lecture, how we are going to face this problem. There was this title, Indications for Treating NAFLD and NASH. Now we have another title, is Targeting NAFLD by Treating Obesity. Why is that we added this lecture to the obesity squad? Because we will fight NAFLD and non-alcoholic fatty liver disease simply by fighting obesity. Which patients with NAFLD needs to be treated? Those with type 2 diabetes, metabolic syndrome, and surrogate markers for this is presence of fibrosis, like in performing fibro scan, and those who genetically have some of the genes we said they are associated with presence of NAFLD. How is NAFLD currently managed? Lifestyle interventions. Of course, Tatiana, she made very nice lecture about this. Bioglitazone, vitamin E, obeticholic acid, but unfortunately no long-term data, and they are not FDA approved. There is no anti-NASH drug that is FDA approved. It's all trials, of course. This comes from the EASL, European Association of Studying Liver Disease, and they are backing me up in saying that it is all about dietary restriction and the progressive increase in aerobic exercises, comprehensive lifestyle approach like energy restriction, stop fructose, stop alcohol, macronutrients, what's called the Mediterranean diet Tatiana told us about, and the physical activity, and the coffee is not related. You can consume it as you can do. Effect of high and low fat diet on the liver fat, and this is the follow-up after performing the lifestyle. After 52 weeks, we can find that even the histology of those patients has improved a lot. What about the medical treatment of NASH? We do not recognize anything to treat NAFLD, but we try to improve NASH. The surrogate target, of course, is to abolish the histologic affection and the improvement of fibrosis. These are the spectrum of drugs they are trying for NASH. Of course, if you want to know about them, we need 7 conferences, 2 lifetimes, and maybe most of them will be deleted because of that. Okay, this is the Bevans clinical trial using pioglitazone and vitamin E and obeticholic acid. They are that they are improving the data as regard in NASH, but the best is targeting obesity by the 3 steps, you know. First, diet and exercise. If you don't know it, then give the anti-obesity medications that you told us about, like orlistat and liraglutide. And if you can do it, just perform the surgery like Professor Iman told us in the obese patients. Anti-obesity medications, of course, orlistat, glucagon-like peptide 1 like liraglutide. They can see, this is the summary of clinical data of NASH medications, and we can see, of course, that they are, most of them, they are improving simply by improving the weight reduction, and those are affecting the hepatic histology. They are either limited data or unknown or not changed. The only one is the obeticholic acid, which improves the hepatic fibrosis, but unfortunately it is still not approved. There is so much interplay between obesity, liver. It is considered now the current era pandemic. Obesity-driven pathophysiology of NASH is parallel hit theory. Some or even all work together. The spectrum of disease carries much morbidity, including hepatocellular carcinoma and even mortality underneath the story. Lifestyle modification and weight loss, and not serving you dinner after this lecture. All of that, of course, they remain the most approved modality for fighting both obesity and NASH. The ideal approved medical therapy for NASH is still a dream to you, to me, and to everyone. This lecture, among hundreds of lectures, are present on my YouTube channel. Please come and visit me. Thank you very much.
Thank you, Professor, and it was a really interesting